A man walked into the emergency room at 4 in the morning, 63 years old. No history of heart disease. Exercised 3 times a week. Watched his diet. Did not smoke. Did everything his doctor told him to do. That night, he woke up gasping for air, unable to lie flat, his heart pounding in a rhythm he had never felt before. His ankles were swollen to twice their normal size. Diagnosis: acute heart failure. The cardiologist ran every test. Genetics: clean. Coronary arteries: open. Diet: not the problem. The cause was sitting in his medicine cabinet, a common, widely prescribed medication he had been swallowing every single morning for 4 years. His own doctor had prescribed it. Nobody ever mentioned what it could do to his heart. That case is not rare. Right now, millions of Americans over 50 are taking medications with a direct, documented ability to damage the heart muscle, disrupt its electrical rhythm, or push it toward failure. These are not experimental drugs. These are not obscure compounds. These are pills you will recognize. Pills that may be in your bathroom right now. And the problem is not that the information does not exist. It does. It is buried in package inserts that nobody reads and clinical studies that never reach the patient. Subscribe and hit like right now. What you are about to hear, nobody is explaining at your next appointment. The system profits when you manage symptoms, not when you understand root causes. Help Dr. Johnson reach 100,000 subscribers so this information reaches the people who actually need it. Today I am going to walk you through 9 common medications that can trigger heart failure. What they do to your heart, how to recognize the early warning signs, and exactly what to ask your doctor at your next visit. Before we touch the first medication, you need to understand what heart failure actually means, because the name is misleading, and most people get it wrong. Heart failure does not mean your heart stops. That is cardiac arrest, a completely different event. Heart failure means your heart can no longer pump blood efficiently enough to meet your body's demands. It is still beating, it is just falling behind. There are 2 main types. The first is systolic heart failure. The heart muscle weakens. It loses its ability to squeeze with enough force. Think of it as a pump that used to push water through a hose at full pressure, now barely managing a trickle. The second is diastolic heart failure. The heart muscle stiffens. It can still squeeze, but it cannot relax and fill properly between beats. Less blood in, less blood out. Doctors measure this with something called ejection fraction. That is the percentage of blood your heart pushes out with each beat. A healthy heart ejects 55 to 70%. Below 40%, you are in heart failure territory. When the heart falls behind, fluid backs up. Into the lungs. That is why you cannot breathe. Into the legs and ankles. That is the swelling. Into the abdomen. That is the bloating and the heavy, exhausted feeling that never lifts no matter how much you sleep. Here is the connection that matters for everything that follows. Certain medications can weaken the squeeze. Others stiffen the muscle. Others flood your body with fluid the heart cannot handle. Others destabilize the electrical rhythm that keeps the pump coordinated. The heart does not fail overnight. It gets pushed there, slowly, silently, by something you swallow every morning with a glass of water. Let me show you exactly which medications do this and how. Medication number 1, NSAIDs, non-steroidal anti-inflammatory drugs. That includes ibuprofen, naproxen, and dozens of brand names you have seen on pharmacy shelves your entire life. Hundreds of millions of people take these regularly for joint pain, arthritis, headaches, back pain. Most of them buy the bottle without a prescription and never think twice. Here is what NSAIDs do inside your body. They block an enzyme called cyclooxygenase. That enzyme drives inflammation, so blocking it reduces swelling and pain. Effective, but that same enzyme plays a critical role in your kidneys. It helps regulate blood flow through the kidneys' filtering units and controls how much sodium and water your kidneys hold on to or excrete. When NSAIDs suppress that enzyme, the kidneys stop releasing sodium and water efficiently. They retain it, blood volume rises, and your heart has to pump harder against a larger fluid load with every single beat. At 30, a healthy body compensates without you noticing. At 55, with even mildly reduced cardiac reserve, stiffer blood vessels, or borderline blood pressure, that extra fluid load can be the push that tips the balance toward heart failure. Clinical data backs this clearly. Studies show that regular NSAID use significantly increases the risk of heart failure hospitalization, particularly in adults over 50. The second medication in this category is high-dose aspirin taken long-term. Low-dose aspirin for cardiac prevention is a different conversation. But when aspirin is used at higher doses for chronic pain, it hits the same cyclooxygenase pathway and produces the same sodium and water retention in the kidneys. Here is the practical reality. These are medications people reach for without a second thought. No prescription required, no pharmacist consultation, no cardiologist involved. And nobody ever connects the swollen ankles or the shortness of breath to the pill they took that morning for a stiff knee. Medication number 3. Pioglitazone. This belongs to a class of diabetes drugs called thiazolidinones. Their job is to improve insulin sensitivity. In simple terms, the drug tells your fat and muscle cells to open their doors wider to insulin, so more glucose gets pulled out of your blood and into the cells where it belongs. For blood sugar control, it works. But the same mechanism activates a receptor called PPR-gamma inside the collecting ducts of your kidneys. When that receptor switches on, the kidneys begin retaining sodium and water at an accelerated rate. The result is significant fluid retention. Patients gain weight, not from fat, from water. Blood volume increases. And the heart, now pumping against a heavier fluid load, is placed under direct sustained strain. The FDA placed a black box warning on this drug for patients with existing heart failure, but here is the problem. Many patients have early-stage heart failure that has never been diagnosed. No echocardiogram was done. No ejection fraction was measured. They are prescribed pioglitazone for their diabetes, and nobody checks whether their heart can handle the fluid load that follows. Medication number 4. Certain calcium channel blockers, specifically the non-dihydropyridine types, verapamil and diltiazem. These are prescribed for high blood pressure and certain heart rhythm problems. They work by blocking calcium from entering heart and blood vessel muscle cells. That relaxes the vessels and slows the heart rate. Sounds protective, but calcium is also exactly what the heart muscle needs to contract with force. In patients whose heart function is already reduced, these drugs can further weaken the squeeze. Ejection fraction drops, fluid backs up, the patient slides into overt heart failure. The irony is sharp. A medication prescribed to protect the heart can damage it if the wrong type is chosen for the wrong patient. Medication number 5. Tricyclic antidepressants. Amitriptyline, nortriptyline. These are older drugs, but they are still widely prescribed, and not just for depression. Doctors use them for chronic nerve pain, migraines, fibromyalgia, and insomnia, particularly in patients over 50. Many people taking these have no idea they are on an antidepressant at all. They were told it was for their pain. Here is what tricyclics do to the heart. They block sodium channels in the heart's electrical conduction system. That is the wiring network that coordinates every heartbeat. When those channels are disrupted, the QT interval, the time it takes for the heart's electrical system to reset between beats, gets longer. A prolonged QT interval is not something you feel, but it sets the stage for a dangerous arrhythmia called torsades de pointes, an erratic rapid heartbeat that can spiral into cardiac arrest without warning. On top of that, tricyclics have anticholinergic effects. They push the resting heart rate higher and reduce the heart's efficiency in patients whose cardiac function is already compromised. A drug prescribed for sleep or nerve pain, quietly rewiring the heart's electrical timing. That is the risk nobody explains at the pharmacy counter. Medication number 6. Proton pump inhibitors. Omeprazole, esomeprazole, pantoprazole. The most commonly prescribed heartburn and acid reflux medications in the world. Millions of people over 50 take them every single day, often for years, often without a clear plan to stop. Most consider them completely harmless. Emerging research says otherwise. PPIs reduce magnesium absorption in the gut. Chronic magnesium depletion directly affects the heart muscle's ability to maintain a stable electrical rhythm. Low magnesium leads to arrhythmias, palpitations, and in severe cases, serious cardiac events. Additional studies have linked long-term PPI use to damage of the endothelium, that microscopically thin lining inside your blood vessels that keeps everything flowing smoothly. Damage that lining, and you impair blood supply to the heart itself. A pill people take for heartburn, quietly undermining the heart it sits next to. 6 medications. That is what we have covered so far. Pain relievers you buy without a prescription. A diabetes drug that floods your body with fluid. A blood pressure medication that can weaken the very organ it was prescribed to protect. An antidepressant that rewires your heart's electrical timing. A heartburn pill that drains the mineral your heart depends on. At least 2 or 3 of those are in the homes of almost everyone watching this right now. Now here is what usually happens. People watch a video like this, feel a knot of concern, and then do absolutely nothing. They go back to their day, the concern fades, and it stays faded right up until a symptom shows up that cannot be ignored. As your doctor, I would never let you walk out of my office after a conversation like this without giving you a next step. So here is what I want you to do right now. Care Health is a free platform that connects you with healthcare options, screenings, and clinical trials in your area. Specifically, cardiac screening programs, blood pressure and cholesterol monitoring, and clinical trials for heart disease and medication safety. All you do is fill in a short form, your date of birth, gender, whether you have children under 18. It takes 30 seconds. It costs nothing, no commitment whatsoever. Care Health matches you with relevant options near you. Click the link in the description below or scan the QR code on your screen with your phone camera. If you are watching on mobile, tap my channel profile picture to find the link. 30 seconds right now is worth more than 30 days of worrying about what you just heard. Now, back to what you need to know. 3 more medications are still on this list, and the next one surprises almost everyone. Medication number 7. Fluoroquinolone antibiotics. Ciprofloxacin, levofloxacin, moxifloxacin. These are powerful, broad-spectrum antibiotics prescribed for urinary tract infections, respiratory infections, sinus infections. Doctors reach for them often because they work fast and cover a wide range of bacteria. Patients take them, finish the course, and move on. Nobody mentions the heart. Here is what fluoroquinolones do beyond killing bacteria. They interfere with collagen synthesis and connective tissue integrity throughout the body. That is why these drugs carry a well-known risk of tendon ruptures, particularly the Achilles tendon. But tendons are not the only collagen-dependent structure in your body. The aorta, the largest artery you have, the main highway carrying blood from your heart to the rest of your body, depends on collagen for its structural strength. When that collagen is weakened, the aortic wall can balloon outward. That is an aortic aneurysm. If it tears, that is an aortic dissection. Both are life-threatening emergencies. On top of the structural damage, fluoroquinolones carry a documented risk of QT prolongation, the same electrical disruption we discussed with tricyclic antidepressants. Moxifloxacin is the worst offender in this class. The QT interval stretches, and the heart becomes vulnerable to dangerous arrhythmias. This risk multiplies if you are already taking another medication that prolongs the QT interval. 2 drugs stacking the same electrical effect on your heart at the same time, and in many cases, neither prescribing doctor knows about the other prescription. Here is what frustrates me as a clinician. Many of the infections these antibiotics are prescribed for have safer alternatives. A standard urinary tract infection, a routine sinus infection, these can often be treated with narrower, older antibiotics that do not carry cardiovascular risk. But fluoroquinolones are convenient, and convenience drives prescribing. Most patients walk out of the appointment with no idea what they are actually putting into their body. Medication number 8. Stimulant medications, amphetamine-based drugs, and methylphenidate. These are primarily prescribed for attention deficit disorders, but here is the clinical reality that almost nobody talks about. A growing number of people in their 50s and 60s are still taking these medications. Some were prescribed them decades ago and simply never stopped. Others started them in middle age as adult ADHD diagnoses became more common. Either way, the prescription carried over while the cardiovascular system underneath it changed completely. Stimulants activate the sympathetic nervous system, that is your body's fight-or-flight wiring. Heart rate increases, blood pressure rises, blood vessels constrict. Every single dose puts your cardiovascular system into a state of artificial stress. At 25, with elastic vessels and a strong heart, the body absorbs that stress without consequence. At 58, with stiffer arteries, reduced cardiac reserve, and possibly undiagnosed narrowing in the coronary arteries, that same stress hits a system that can no longer compensate the way it used to. Over years of chronic use, the heart muscle responds to this sustained overwork the only way it knows how. It thickens. The walls of the left ventricle, the main pumping chamber, grow denser and less flexible. This is called left ventricular hypertrophy. It sounds like the heart is getting stronger. It is not. A thickened heart muscle is a stiff heart muscle. It cannot relax and fill properly between beats. That is the exact mechanism of diastolic heart failure, the second type we discussed at the beginning. The problem is reevaluation, or rather, the absence of it. A medication that was appropriate for a 35-year-old brain may be quietly damaging a 60-year-old heart. And if nobody rechecks, nobody catches it until symptoms appear that can no longer be explained away. Medication number 9. This one is different from the others. Patients did not choose it the way they choose a painkiller or a heartburn pill. This is anthracycline chemotherapy. Doxorubicin is the most well-known drug in this class. It is used to treat breast cancer, lymphoma, leukemia, and several other cancers. It saves lives. That is not in question. But the cardiac consequence is one of the most devastating and least discussed realities in long-term cancer survivorship. Here is the mechanism. Anthracyclines generate free radicals inside the body. These are highly reactive molecules that damage cell structures on contact. Most tissues have antioxidant defenses that neutralize free radicals before they cause lasting harm. The heart muscle does not. Its antioxidant capacity is limited compared to other organs. That makes the heart uniquely vulnerable to anthracycline damage. The injury is cumulative and dose-dependent. Every infusion adds to the total. And here is the part that catches people completely off guard. A patient who received chemotherapy 5, 10, even 15 years ago can develop heart failure now. The cancer is gone. The treatment ended years ago. But the heart muscle was silently injured during those infusions and has been gradually declining ever since. The damage does not announce itself until the heart crosses a threshold it can no longer recover from. This is called cardiotoxicity. Oncologists today are increasingly aware of it. Many now order echocardiograms before, during, and after treatment to track ejection fraction. But cancer survivors from earlier decades, people treated in the 1990s or 2000s, were often never monitored for cardiac effects after their chemotherapy ended. If you or someone you love underwent chemotherapy involving anthracyclines at any point in their life, cardiac follow-up is not optional. Not even if you feel fine, not even if the cancer is a distant memory. The heart remembers what the mind has moved past. 9 medications, 9 different mechanisms, and a question that every patient eventually asks: why did nobody tell me? The answer is not conspiracy. It is not that your doctor wants you harmed. The answer is how modern medicine is structured. Most of these drugs were approved based on their primary therapeutic benefit. The NSAID reduced inflammation. The PPI stopped acid reflux. The calcium channel blocker lowered blood pressure. Those benefits were clear, measurable, and immediate. The cardiac risks emerged later, sometimes years later, from post-market surveillance, long-term population studies, and accumulated clinical observation that was never part of the original approval. On top of that, your care is fragmented. A rheumatologist prescribing for arthritis is focused on your joints, not tracking your ejection fraction. A psychiatrist managing your depression may not order an ECG before writing a prescription for a tricyclic. A gastroenterologist treating your reflux is thinking about your esophagus, not your magnesium levels. Each specialist sees their own window. Nobody is standing back and looking at the entire wall. That is not a reason to distrust your doctors. It is a reason to become the person who sees the full picture. And the tool for that is simple: a personal medication audit. Sit down, write out every single medication you take: prescription drugs, over-the-counter pills, supplements, anything you put into your body on a regular basis. Next to each one, note how long you have been taking it. Then bring that list to your next appointment and ask one specific question about every item on it. Has this been evaluated for its effect on my heart at my current age and health status? That is not confrontation. That is collaboration. You are not challenging your doctor. You are giving them the complete picture that a 12-minute appointment and a fragmented system never provided. Now a clear, practical action plan. Here is exactly what to do after watching this. 1. Write down every medication you currently take: prescription drugs, over-the-counter pills, supplements, anything you take on a regular or as-needed basis. Every single one. The bottle in your medicine cabinet and the ibuprofen in your desk drawer both go on this list. 2. Next to each one, note how long you have been taking it: months, years, decades. Duration matters because many of the cardiac risks we covered are cumulative. They build over time. 3. Bring that list to your next doctor visit and ask one direct question about every item. Does this medication carry cardiovascular risk at my current age and health status? Not at the age I was when it was first prescribed. Now. 4. If you are currently taking any of the 9 medications covered in this video, do not stop them on your own. This is critical. Abruptly stopping certain drugs can be more dangerous than continuing them. The correct move is always a conversation with your doctor, not a unilateral decision made at home after watching a video. 5. Ask whether you have ever had a baseline echocardiogram. That is the ultrasound of your heart that measures ejection fraction. If you have never had one, ask whether it is appropriate given your medication history. 6. Learn the early warning signs of heart failure. Unexplained shortness of breath, swelling in the ankles or legs, sudden weight gain over a few days, waking up at night gasping for air, persistent fatigue that worsens when you lie flat. These are not aging, these are signals. If you experience any of them, tell your doctor immediately and mention what you are taking. 7. Share this video with someone you care about who is over 50 and takes daily medications. How old are you? Write it in the comments. I want to know which age group this hits hardest so I can focus future content exactly where you need it. 9 medications, all common, all widely prescribed, all carrying a documented ability to push the heart toward failure through fluid overload, electrical disruption, muscle damage, or vascular injury. NSAIDs that flood your system with fluid, diabetes drugs that do the same through a different pathway, blood pressure medications that weaken the very organ they were prescribed to protect, antidepressants that rewire the heart's electrical timing, heartburn pills that drain the mineral your heart depends on, antibiotics that compromise the structural integrity of your largest artery, stimulants that place the heart under years of artificial stress, chemotherapy agents that silently injure the heart muscle long after the last infusion. The heart does not fail without cause. In many cases, the cause is something you can identify, discuss with your doctor, and modify before the damage becomes irreversible. Your doctor is your partner in this, but you must bring the questions. You must bring the list. Nobody is going to ask those questions for you. That is not how the system works. It never has been, and remember, that free health screening link is in the description. 30 seconds could make a real difference. Take care of yourself. Walking is one of the most powerful things you can do for your heart, but the pills sitting next to your walking shoes matter just as much. Small changes in what you know and what you ask produce real long-term results for your heart, your safety, and your life. Subscribe to Dr. Johnson, leave a like, and help this reach the people who need to hear it before their next refill. One informed person at a time. That is how we change this.